Hello everyone, it's Abdullah here and I'll be covering on this video polycystic kidney disease. As you see here in this growth pathology, you can see two kidneys and the ureter is coming out from the posterior surface, and you can see multiple dilated cysts all over the kidney, and they are fluid filled as well. So the way we define so this is the growth pathology of this condition, polycystic kidney disease. You can see multiple cysts in both kidneys, and cysts are fluid-filled cavity. The mode of inheritance in this patient, so the way I remember it, you have two different types of polycystic kidney disease. You have an adult type, okay, and the children type as well. All right. So the children type, they usually don't make it to life really, because they will have other associated problems as well. But adult, it starts with AD, so it's an autosomal dominant condition. So a child is an autosomal recessive condition. So this one is autosomal dominant condition. What is the pathogenesis of a cyst formation? So we do have in a cyst formation, there'll be initially, we have the renal tubules, there'll be sort of inactivation of the division, and there'll be continuous division of the cell until it will start forming something called outpocketing from the wall, and then this pocket will start to be fluid filled until it gets bigger and bigger, all right, until the later stages will be separated after expansion, and this is or isolation and growth. So it starts by inactivation and continuous division, and then outpocketing, and then following that, division continues and the cyst starts separating renal tubules, and it will completely separate to form a fluid-filled cyst. So the problem with a fluid-filled cyst, it will replace the normal tissue of the kidney, and then consequently can lead to renal failure. That's one. But the other thing is with renal failure, it's a fluid filled, so this fluid might get infected, so it can cause significant pyelonephritis, all right? Pyelonephritis, and can even be a risk factor for developing cancer later on. So usually by the age of 35, patients will need renal transplant, okay? Renal transplant or some sort of an alternative treatment, okay? But these cysts are mostly associated with a few other conditions. So it can be associated with cysts somewhere else in the body, and that can be the ovary, can be the pancreas, and can be the liver and the spleen as well. And also can be associated with an aneurysm, specifically brain aneurysm. All right. That's why if you have a patient with polycystic kidney disease coming to you with sudden severe onset headache that's not responding to painkillers, mostly it's an aneurysm, and we need to do further investigation. The treatment is always renal transplant. And when we go to this point of renal transplant, you might be asked a little bit about how to do renal transplant, and also the indication, and also, most importantly, the graft rejection, all right? The graft rejection, which we're going to talk about it in a minute. But looking at this, you have germline mutation and inactivation of the gene, leading to frequent division of these cells until it forms an outpocketing from the wall. It will continue to expand until it completely separates, and it will be a fluid-filled cavity that will be a higher risk of developing infection and will lead to renal failure as well. Great. The complications, we talked about renal failure, hypertension, and infection as well. The associated brain lesions could be a cerebral aneurysm. And we talked about the treatment very shortly, that we'll need to do some sort of renal transplant. And to do that, we need to do some sort of matching before this. And this matching is HLA, A, B, and DR, and the ABO system. Types of graft rejection. This could be a hyperacute rejection, or acute rejection, or chronic rejection. So, obviously, it's a classification based on time. So, hyperacute rejection, can happen immediately. And this when the patient has antibodies preformed antibodies against the donor kidney or the donor blood. So this could be whether it's an Rh incompatibility or ABO incompatibility, and in that case, the kidney needs to be removed immediately. In acute type, it could happen in the first week and it could happen in the first 100 days. So in the first week, it's called accelerated. In the first 100 days, it's called just acute graft rejection. And it's usually T cell mediated and characterized by diffuse lymphocytic infiltration and arthritis as well. And the treatment will usually be high dose steroids. The chronic graft rejection, this happens from 1 month to a year, and it's usually due to sort of intimal thickening of the vascular or the blood supply to the kidney, and consequently will lead to fibrosis. All right? Great. In immunocompromised patients, there are at specific risk of certain type of cancers, and this includes squamous cell carcinoma and basal cell carcinoma of the skin, and also lymphoma and Kaposi sarcoma as well. Thank you.